let's get into the important stuff. Okay, you are dispatched to a private residence for a 6-year-old who looks to be in a pool alone. The neighbor saw him and called the police as it looked like he was struggling. Police arrived just before and pulled the patient out of the pool and handed him over to you. The patient is blue, limp, and not conscious. So this is your patient here. You can see the police jumping in, finding the patient in the pool, and handing over to you. You'll get another look at the presentation. So unconscious, blue, cold, and limp. Okay, we'll take another look at the vital signs in a sec, so I'm just going to keep passing through there. Okay, so in this particular patient, we have flaccid limbs, we have signs of cyanosis, they're blue, we have signs of hypoxia, meaning that they're blue, they're unconscious, they're altered, and then we have something that's going to happen during ventilation, which we're going to talk quite extensively about, which is foam and bubbles from the mouth during ventilation. And finally, we can see, especially in pediatrics, profound bradycardia as this hypoxia gets worse and worse and worse. So judging by what we are seeing here, we are seeing a patient that it looks like that they are profoundly hypoxic. And let's take a look at the vital signs as well in a sec, so that way we can kind of confirm our findings. So what's this patient's issue? Why are they profoundly hypoxic? Well, it's because of how much obstruction is in the way inside the alveoli. So what you're seeing here is just simply fluid filling these alveoli. And when you have fluid that's filling the alveoli, unfortunately, oxygen can't get through. It can't get to the alveoli. And so our goal is going to be to reduce the amount of fluid inside the alveoli using pressure of ventilation in order to move oxygen further into the alveoli, giving it some open surface area to work with in order to diffuse into the blood and oxygenate the red blood cells. So that is our goal in this particular patient. Okay, so let's take a good look at these vital signs. So we know what our patient presentation is. Now, these are our vital signs. We have a heart rate of 142, sinus tachycardia, blood pressure 76 on 47, and an SpO2 is 78. End-tidal CO2 failed, and we'll talk about that in a sec as well. So, judging by these vital signs, what are they telling us? Do they confirm our findings? What do you think? Throw it in the comments. Do they confirm our findings that this patient's profoundly hypoxic? I would agree with you. Okay, so I believe that they are profoundly hypoxic, and the vital signs confirm that. Just judging by the patient presentation, they're blue, they're flaccid, they're altered level of consciousness, and they are not conscious. And then the vital signs confirm our findings, saying that this is likely a profound hypoxia that's causing all of these symptoms. So now, taking another quick look at these vital signs, there's something else that we need to probably take a note of, and that is the blood pressure. Now, this patient is 6 years old, so is a blood pressure of 76 on 47 actually hypotensive for this patient? Go ahead and put the answer in the comments. Is this patient actually hypotensive for his age? What do you think? Oh, I see a lot of yeses and I see a lot of no's. The answer is yes. This patient is hypotensive. How do we know that? Well, going back to our vital signs or our blood pressure, here's a quick little equation for you. It is 70 plus 70 plus 2 times their age. Okay, so in this particular situation, 2 times their age, he is 6. So 2 times that age is 12. So his hard line of hypotension is actually 70 plus 12, which gives us 82. So yes, this systolic here is hypotensive. What's the cause? We'll probably have to investigate that further, but likely due to profound hypoxia that's now causing a failure of sympathetic tone. So yes, this patient is hypotensive for his age. Okay, so we have a patient, as we know, is profoundly hypoxic and hypotensive. We have the alveoli completely filled with fluid, so we have no oxygen exchange that's going to occur here. How do we correct that problem? How do we improve oxygenation in a drowning patient that we can't get or they can't get oxygen into the alveoli? How can we fix this problem? Go ahead, put that in the comments. How can we fix this problem and get oxygen down on those alveoli? Positive pressure ventilation. Okay, I like it. What other options? PEEP. Okay, we're going to talk about PEEP. Suction, sure. High flow oxygen. I love it. You guys are thinking on the right track. CPAP is not a terrible idea if this patient was conscious. They're not. So unfortunately, we wouldn't be able to use it in this situation, but I don't hate the idea of using CPAP in this situation if they were conscious. But unfortunately, they have an altered level of consciousness. They are unconscious, actually, and so we're not going to be able to do that. But I don't hate the idea of considering it in a patient that is not this far gone. Okay, but your answer is correct. What is the way that we can improve this patient situation? Is ventilation and ventilation and more ventilation. Okay, that is what we need to focus on, is improving ventilation as much as we possibly can. So in doing that, when you are going to notice, even with a mask ventilation, is that you're going to notice foam and bubbles coming up out. And that is because you're forcing air down to the alveoli and it's pushing back up and pushing through the fluid. And by pushing through the fluid, it's mixing all that fluid, that's that water and the surfactant that's mixed, it is coming up as bubbles, as bubbly fluid. And so when you ventilate, you're going to likely see that. And so keep in mind that you're going to be suctioning quite a bit with this patient. This is kind of what it looks like. Okay, so a lot of fluid that has a lot of bubbles in it that needs to be suctioned, needs to be cleared. Okay, one thing that I want to mention, just going back to the mask, is that you'll notice that this is a two-handed technique, not a one-handed technique. One thing in drowning patients, what we require pressure in order to get that air that we're delivering past all that fluid and into the alveoli in order to force the fluid out. Okay? In order to do this, we need to have a good seal. As good of a seal as we possibly can make. And the best way with a mask ventilation to create a good seal is to use two hands. And so in this situation where ventilation is absolute paramount for this patient's survival, this needs to be a huge focus, is good basic ventilation in order to maintain good pressure and getting air into the lungs and limiting the escape of pressure outside the mask. Okay? Another thing to take in consideration that happens when you have so much surfactant bubbles and fluid bubbles that you're seeing here is that if you have an end-tidal CO2 side stream on this patient, as soon as those bubbles reach the tubing, the sampling line, it's going to clog it and you're going to lose and you're going to fail your EtCO2. Your EtCO2 is going to be pretty much useless. So don't be surprised if you have to swap out your EtCO2 tubing and your monitor on a regular basis with these patients, because it doesn't take much for it to clog when these surfactant bubbles get in through that sampling line. So don't be surprised if that happens. Okay, so we have good ventilation on this patient. Okay, we have a good seal with mask ventilation. We've used an OPA. We may be using 2 MPAs to try and maximize the amount of air entry. So my question to you is, at this point, what are some indications to suggest that this patient needs an advanced airway? Go ahead, put that in the comments. What are some reasons that this patient would need an advanced airway? What are you looking for to tell you that? GCS 8 or less, I would suggest that we have that right now, but there's some other things that are really telling us that can give us a very good guide. Cannot protect their own airway, I'd say that's pretty much there. Obstructed airways, respiratory failure, unable to maintain airway, failure to maintain airway. I agree. So here's a very simple, straightforward answer to this. Is that when you are ventilating your patient, let your vital signs be your guide. Okay? So you are using two-handed mask technique. You are using an OPA and maybe double NPAs in this patient. So what you want to be doing in this situation, if you can use your EtCO2, great, to determine if you are getting good airflow and ventilation. But a lot of time, your best indicator is going to be how your SpO2 is doing. If you're using all these strong basic techniques and everything is going well, you're maybe even using a PEEP valve, which we're going to talk about as well in a sec. Maybe you're doing all these things and you continue to reevaluate your SpO2 and it's still high 70s, low 80s and continuing to get worse or not improving. This would suggest that what we're doing right now is not enough in order to displace enough fluid in order to oxygenate the alveoli. So your best indicator that you need to introduce an advanced airway in this patient is looking to see if your patient is improving. If they continue to deteriorate, we need to advance the airway. Okay? That is how you determine whether you need to move forward or not. Okay? Now this airway isn't going to be fun. Okay? It's going to be a difficult intubation. It's going to require a lot of work. Now, my question to you is, should we just go for an SGA as opposed to intubating this patient? Go ahead, put that in the comments. Do you think that you would want to go SGA on this patient to avoid having to do a difficult airway? Go ahead, put it in the comments. So some people are saying it won't help. Can you elaborate? I'd love to know your thoughts on it. An SGA is a supraglottic airway, so it doesn't capture the glottic opening, it kind of covers it as opposed to capturing it. That's what an SGA does. There's a picture shortly that will show it. So there's some very interesting things about an SGA, particularly dealing with drowning patients. Okay. When you place an SGA, this is what an SGA looks like. This is an LMA. But this one is covering the glottic opening as opposed to securing the glottic opening. So when we intubate a patient, we're securing this area as opposed to just covering it. Okay? There's a few reasons why this is an issue in particularly drowning patients, and there was some case reports to back that up, is that typically we are ventilating, when we're ventilating a patient, we're trying to introduce a limit of how much pressure we put into the lungs. And so this gets a little bit advanced, but the amount of pressure that we typically want to have the lungs under during peak inspiration, so when I squeeze the BVM, when I've delivered that full breath, there's a point of pressure that I've delivered. And we try and keep that pressure point under 30. So that's typically what we're trying to do. In a drowning patient, when we're trying to maintain air to get underneath that fluid and force it out, we typically need higher peak pressures, about 10 points higher, around 40. And so there was a case report that came out, mind you, in 2011, that suggested that they've reported failures of SGAs, particularly the iGel and the Aurora ones from Ambu, that failed in this particular drowning situation. And the reason being is that when they tried to increase pressure in order to try and get some of that fluid out, they noticed that there was inadequate ventilation from the iGel and the Aurora ones, as well as escape of air into the stomach and developing air pressure in there. So if you choose to use an iGel or any type of SGA, mind you, this is 15 years old, almost 15 years old. So obviously SGAs have improved since then, but it's important to know that there is a possibility of failure. So if you choose to go with a supraglottic airway in this particular situation, I would be very diligent in paying attention to if it's working. And the best way, again, to identify if it's working is seeing if your semi-capture of the airway is improving your oxygenation status. That should be your gold standard of seeing if anything is working and improving your ventilation status. And so if it is not, and your end-tidal CO2 is suggesting the same, then you probably need to look at pulling the SGA and introducing a ET tube to secure the airway truly, so that way we can deliver proper pressure for this patient. Okay, so I'm not saying don't do it. I'm just saying use it with caution and reevaluate on a regular basis to confirm that it's actually working, because there is precedent of failure. Okay, so let's say we decided that we intubate this patient, which I think we are probably going to be heading that direction, especially if our basic ventilation skills are failing and we continue to have poor ventilation and poor oxygenation. So here's some things that are important for this particular scenario where it's a pediatric. One, we're going to likely need suction. We're almost certainly going to need suction prior to intubation in order to clear the airway so we can actually see what we're doing. Second thing, a correctly sized ET tube is going to be important. A correctly sized laryngoscope is going to be important so we get a proper view. And I would highly, highly recommend a bougie. Highly recommend a bougie. This is a difficult airway. Difficult airways have a much higher success rate using a bougie as opposed to not. So how do we know which ET tube we need to use? Well, he's 6 years old. So there's a Dirichlet's formula that we can use. That is age divided by 4 plus 3.5. There are tables you can memorize. I find this easier to quickly do it on your phone. And in this particular case, we have 6 divided by 4. His age divided by 4 is 1.5. 1.5 plus 3.5 equals 5. So that is the size of tube that would be a proper fit for this 6-year-old. Okay. Next thing is your blade. Now, typically a Miller blade is recommended to pediatrics that are up to about 2 years old. And then after that, it starts kind of getting more towards your Mac blade, your Macintosh blade, which is the more common one that you see that's curved. In this particular patient, he's 6 years old, and the charts that I've seen between 6 and 12 years old, typically they recommend anything from a 2 to a 3. Because he's on the lower end of that chart, I think a 2 would be the most appropriate, but knowing that you may need to swap out that blade as well as the tube in case something occurs here. So in these particular situations, when I'm setting up, what I'd be grabbing, according to these charts and these formulas, is a 5 ET tube and a 2 blade. And I'm preloading that tube with a bougie. Okay, so in order to kind of do this intubation, what we need to do is that we need to try and get a clear view. So in this particular situation, we're going to have fluid that's really in the way here. And so what we need to do is that we need to, first off, tip the head in order to draw fluid down first. And then what we're going to do is that we're going to introduce our suction. If you have a Ducanto catheter, great, use it, because it's designed for these types of airways. If you do not have a Ducanto catheter, using an OG hooked up to your suction, using a flexible tip, using a Yonker, all of these would be effective, but if you have a Ducanto, use it. Suction down the airway as much as you can, particularly the glottic opening, like so. So that way you have a clear view when you attempt this airway. Now you're still going to have some bubbles, some fluid around there, particularly lower down. And so when you get this view, intubate, particularly with a cuffed tube, not a non-cuffed tube. In this particular situation, the reason being is that we want to deliver more pressure, and a cuffed tube will be able to do that more appropriately. Okay, so we've intubated this patient. We've used a cuffed 5 tube. We successfully suctioned down there so we can actually see what's going on. So we got visual confirmation. Make sure that you are listening to lung sounds. If you still are able to and your ETCO2 hasn't failed, use that to confirm airway capture. Always use 2 to 3 confirmations of airway capture, so that way we know we're in the right place. Okay? Especially if your ETCO2 is failing, use as many modes of confirmation as you possibly can. Okay? So we have captured this airway, but our alveoli still look like that. We still have a significant amount of fluid in them. What is a tool that we can use that attaches to the BVM that can help improve this problem? So in other words, how can we continue to improve oxygenation in this patient? I love it. You guys are on the right track. The best way that we can improve oxygenation, now that we have a captured airway, we're introducing good ventilations, we know that we're moving that air into the lungs, is that we want to introduce PEEP. And so typically with a BVM, with a PEEP valve, you typically would start at 5 centimeters of water on your PEEP. I would be surprised if you ended at 5 centimeters of water of PEEP. Because we can increase the PEEP in order to do a few things, one of them being expanding the alveoli. And by expanding the alveoli, we're creating more surface area that oxygen can use in order to diffuse into the blood. So that's what PEEP does. And for those of you who are unfamiliar with PEEP, what PEEP essentially is that it's going to create pressure at the end of expiration. Without a PEEP valve, what happens after you've bagged them with a BVM and you've relaxed, you're in that relaxation phase of the ventilation, that exhalation phase, what happens without pressure inside the alveoli is that they are at risk for collapsing, causing a telecastus and very difficult to open those airways again. So PEEP basically keeps the alveoli from collapsing, holds them open with pressure. And so we're maintaining, with a 5 centimeters of water of PEEP, we're maintaining 5 centimeters of pressure against the walls of the alveoli. And in order to improve oxygenation, we can increase the PEEP in order to maintain more pressure against the alveoli that stretches them out during the exhalation phase. So that way we don't have to work so hard to introduce air again. So typically you would increase your PEEP every few minutes after you reevaluate. So that's my next question is, how would you know if you need to turn up the PEEP? How would you know if you need to turn up the PEEP? Any ideas? Robert's got it. The best way to know if you need more PEEP is to check your oxygenation status. By now we should see that the oxygenation status is starting to improve now that we've captured the airway, we've cleared some of that fluid with suction, with ventilation. We're on the right path. You likely will see the blood pressure start to improve as the SpO2 starts to improve, maybe even the heart rate coming down. So we're in a good spot. We're a better spot, I should say. So the best way to determine if we need to increase the PEEP is to monitor the SpO2. So when you hook up a PEEP valve and you see, okay, SpO2 is at 82%. Not awesome. Not terrible either, considering where we started. Now reevaluate that. We know that our baseline of 5 centimeters of water of PEEP is at 82%. We can increase to 7.5. Reevaluate in 3 minutes. If we see that it's 84, 85%, okay, we're in the right direction, we're moving. Let's try 10. You see that the SpO2 is now rising into the high 80s, and it continues to rise. That is how you determine whether you need more PEEP or not, is to watch your SpO2, watch your oxygenation status in order to determine what we need to do. Okay, so that's how you use PEEP in order to guide oxygenation status, or using oxygenation status in order to determine how much PEEP you need. And the whole idea of this is by increasing PEEP and why it improves oxygenation is that the more we expand the alveoli, the more surface area that's unobstructed with water, the more likely we're going to be able to get that air, oxygen air, into the blood. We also have inflammation. Water is it's irritating to a lot of the epithelial tissue. And so PEEP, stretching out that tissue, allows for more ability for transfer in there. So there's a few things that are going on here inside the lungs, and PEEP is a benefit to both of them. Any questions with anything that we've covered with this patient? Go ahead and put them in the comments.